Classifying mental disorders involves categorizing in groups of symptoms into mental disorders and then categorizing the disorders into classes. Diagnosis is the process of deciding what, if any, mental disorder a person is suffering based on their symptoms. In order to provide effective treatment of an abnormal condition, the condition needs to be accurately diagnosed. Diagnosis, in turn, depends on the availability of a comprehensive classification system of all possible abnormal conditions. A classification system is simply a comprehensive list of categories, including detailed descriptions of the symptoms and characteristics of each. In this section, I'm going to be looking at the two main classification systems used in the field of mental health, which is the Diagnostic and Statistic Manual of Mental Disorders, also known as the DSM, and the International Classification of Disorders, the ICD. The first DSM was published in 1952 because the US Armed Forces wanted a guide on the diagnosis of servicemen. The first version had ideas that would be shocking today. Infamously, homosexuality was listed as a sociopathic personality disorder in the DSM-1 and 2 and remained so until 1973. Because our understanding of mental health is evolving, the DSM is updated at regular intervals, and in each revision, mental disorders that are no longer considered valid are removed, while newly defined disorders are added. The Diagnostic Statistic Manual, the DSM, was created to help psychiatrists to communicate using a common system of diagnosis. Its forerunner was published in 1917, and it contains statistics gathered across mental hospitals. There are several systems which can be used to clarify abnormal patterns of thinking, behaviour and emotions into mental disorders. These systems are highly detailed. They both classify abnormality into many different disorders, as well as giving guidelines on how to diagnose them. In some cases, this includes standard interview questions to help the diagnosis. Classification of a mental disorder involves taking a set of symptoms and putting them into categories in order to identify a particular diagnosis. These categories can then be classified as one of a wider class of disorders. So below are listed the major classes of disorders from the DSM-4 revised. Once doing diagnosis, a set of symptoms have been classified into a disorder, it's possible to diagnose an individual. This involves assessing the presented symptoms and deciding if they meet a set criteria for a mental disorder. To diagnose a mental disorder, a certain amount of symptoms need to be present for a certain amount of time, and possible the non-presence of other symptoms that indicate other disorders. So to diagnose dysrhythmia requires depressed mood plus 2 other symptoms to be present for 2 years, 1 in children, and that the symptoms are not the result of medication or a medical condition. The DSM was developed in response to the need of a census of mental health disorders, because previous attempts only used descriptions and classifications such as psychosis and neurosis, and for these classifications and descriptions, lists of symptoms were gradually developed and then refined, and the DSM evolved from these. The main reason for the classification of mental disorders is to give people a diagnosis. This can help to give them appropriate treatment and services, and it can also help both patients and families to understand their behaviour. The DSM-4 revised, which was published in 1987, showed that diagnosis takes place on 5 different bases or axes, and it's therefore called a multiaxonal diagnosis. A multiaxonal system is where the individual is assessed according to more than one criteria. So, for example, the individual will be assessed on the 4 criteria or axes listed below. Although clinicians are not obliged to use all 5 axes during a diagnosis, it is recommended. Axis 1 lists the major clinical disorders from which the patient is suffering, e.g. schizophrenia, anorexia, depression, etc. A diagnosis is made on the symptoms presented. In addition, other circumstances that may require intervention are noted here, including stress-related physical symptoms or a history of sexual abuse. Axis 2 are whether lifelong, deeply ingrained, inflexible and maladaptive behaviours which may occur independently of Axis 1, such as personality disorders, antisocial personality, or severe learning difficulties. This is essentially the person. The presence of Axis 2 alongside Axis 1 generally means that the person's problem will be a little bit more difficult to treat. They may not need immediate treatment, but it will affect treatment. Axis 3 looks at general medical conditions, and this lists any medical conditions that may be relevant to the mental health disorder in question. So, for example, the existence of a heart condition, who needs to be diagnosed with depression, because this would have important implications for the treatment, because some antidepressant drugs could worsen this condition. Axis 4 is where the psychosocial and environmental factors that may affect the diagnosis, treatment and the prognosis of the disorder, such as occupational, economic, relationship difficulties a person may have, such as experienced by a stressful event such as divorce. And finally, Axis 5 considers areas of social relationships, occupational functioning and the use of leisure time. An assessment is made of how well a person is coping with everyday life. A global assessment of functioning scale is applied from 0 to 100, where a low score denotes some danger of hurting themselves or other people, and a high score denotes a superior level of functioning. Diagnosis, according to this system, means assessing the individual separately on 5 different axes. So, for example, somebody might be involved in alcohol or cocaine abuse, which is Axis 1. They may have personality disorder, in Axis 2. They may have some related medical condition, Axis 3. Behavioural problems, Axis 4, and therefore be at risk of self-harm, Axis 5. Each of these is taken into account when forming the diagnosis, although often only one of them will be labelled as the principal diagnosis or as the main problem. As I mentioned before, the DSM is regularly revised and changed, and there have been a number of revisions on the DSM. The most recent one is the DSM-5, which changed its attitude on homosexuality and cultural attitudes. The strengths of the DSM as a common diagnosis tool. Through its many revisions, the DSM has stood the test of time. It's possibly and arguably the best attempt at diagnosis in existence, given the limited understanding of mental disorders. When more than 2 doctors use the DSM, they should usually come close to the same diagnosis. One study that tested the reliability of the diagnosis between the DSM-2 and 3 is Goldstein, and she found that there was evidence of reliability within the DSM-3. Causes for mental illnesses can be looked at more successfully if everyone within the illness is grouped together under a diagnostic label. Research can then be carried out, so for example whether patients with a particular disorder have any common experiences, and once this is clarified then we can use this to create adequate treatments that may be proposed in order to be able to help the people. Weaknesses. The DSM is seen as a confirmation of a medical state of mental disorder, as sufferers are seen as patients and treatments are suggested. Mental health issues become disorders and illnesses, so cures are looked for. However, it may be said that some mental disorders are simply ways of living, and who is to say whether these are illnesses or not? Lang suggested that schizophrenia is another way of living where a person is trying to get back to their true self and is therefore not seen as a medical illness. Due to the principles of self-fulfilling prophecy, patients may act in relation to their label and therefore worsen their disorder. The label is also attached to the whole person, and because of this, any behaviour which the individual exhibits at a later date is then judged, in light of this label, even though it might have nothing to do with the disorder. Institutionalisation can lead to a loss of responsibility and increased depersonalisation, dependency, and a loss of self-care skills, as found by Rosenham. Patients may also be taught abnormal behaviour from those around them in an institution, and conditions do not help normal functioning since they're not treated as normal people would be. Also, by being labelled as mentally ill, a patient can have implications for going back into society and the stigmatisation and discrimination experienced. There are also ethical implications. The important downside of receiving a psychiatric diagnosis is the risk of social stigmatisation. Skinner et al. Surveyed American college students on their attitudes to ex-psychiatric patients, ex-drug addicts and ex-convicts, and they found that there was considerable negative stigma attached to mental disorders.